Welcome to the 13th webinar in the MDHS Institute Interprofessional Webinar Series. Today, the topic will be Assessment and Management of Dyspnea in Advanced Illness. My name is Pauline Lesage, and I am one of the physician educators at the MDHS Institute for Innovation in Palliative Care. Noting no conflict of interest, but I must say that, before we go further, that I do have a personal interest, or great personal interest in that topic, since I live with a father who died of COPD at the age of 69, and for which we had to disconnect the ventilator. Therefore, I was exposed to dyspnea, or what is it to live with dyspnea, for a long period of time. And so I hope that I'm not biased by what I'm going to say, but I may be. Let's start here by saying or reading a sentence that you heard so many times. And this sentence is extracted from one of the clinicals that we received this week for somebody who wanted to refer a patient to hospice and palliative care. And this was coming from a great university hospital. So here's the scope, and this is something that I'm sure you heard about. Somebody saying, she states that she is short of breath, meaning the patient, but she appears comfortable. It seems that there's kind of a disconnect here. We have a sense that the patient is complaining of something, but we don't really agree with that because this is not what we are seeing. And so you already see that we are somewhat biased in a way that we evaluate the patient. It's a little bit the same for pain. Remember, the pain is sometimes the patient saying, I'm in pain, but we look at them and they say they don't grimace, they are not in pain. How can they say such a thing? So keep that in mind, because I hope that at the end of this talk, we are going to see a little bit differently and not to write this sentence ever again. If patients say that she's short of breath, it's because she's short of breath. I will discuss a case along the presentation. So we'll start with the case and we'll come back on and on till the end of the presentation. So bear with me, we won't have the solution right away. It is just that we need to sort of go along with the presentation. So this is a 70-year-old man with metastatic colon cancer, metastasis to the lung and the lymph nodes. He came to the ED for dyspnea for a week duration and hypoxia 85 or higher at room air. Chest X-ray showed consolidation of the left lower lobe. He was given antibiotics, sent home, and the idea is that after a full course of antibiotics, 10 days, the patient dyspnea remains a problem. Had improved somewhat, but still is there. What will you do? At this point, I would say if you were to call me and ask me what to do, I would say I don't know, because we don't know enough about the patient. We don't know enough, and you will see how this is coming in with what goes along in this session. We don't know enough about where the patient is in the course of his illness. Shall we be aggressive? Shall we start looking for multiple etiologies? Or shall we just go symptomatically? We don't know what is his PPS, his score, and so on and so forth. So for now, we are not sure exactly how we should manage this patient. Let's sit there for a minute, and then we'll continue and we'll come back to it. Dyspnea, what we are going to do today is go through the usual pattern for any symptoms, usually some definition, prevalence, etiology, pathophysiology, assessment, and management. Definition of dyspnea is really, and this is what we need to really understand and to distinguish from some of the terms. It's a subjective perception of difficulty breathing. So it's you as a person who say, I'm not breathing well. Only the person per se can say it, therefore. So a little bit more elaborate definition will be, dyspnea applies to sensation experienced by individuals who complain of unpleasant or uncomfortable respiratory sensation. It's a subjective feeling. They will say, I feel some tightness, I don't feel well, I feel that I don't have enough air. There's multiple language that they can use, but it's a personal experience. It should be distinguished with what we call tachypnea. Tachypnea means increased respiratory rate. Patient is breathing fast or slow. Tachypnea means fast, and bradypnea will be slow. May or may not correlate with cardiopulmonary dysfunction. We'll come back into that in a minute, and can involve physiological and psychological issues. Those two issues here are very important, and you will see how they will play a role in on dyspnea along when we are going to discuss further. So far, dyspnea is a personal, it's a subjective feeling. How dyspnea is prevalent. And I was surprised by reading and preparing for this lecture how common dyspnea is and how we don't know much about on various aspects. As far as etiology, as far as treatment, assessment, we are still struggling to find really a great management of dyspnea. But look at the statistic, and in cancer population it can be as frequent as almost 80% in the patients, especially in advanced cancer obviously, and for patients who has cancer of the lung or metastasis to the lung. In AIDS population about 68%, but the stunning statistic is that it's about present in 50% of patients admitted to acute tertiary care hospital. That's a kind of a high number, and in about 25% of ambulatory patients. So we better be good at dealing or managing dyspnea because it's something that's present oftentimes. Just a reminder that dyspnea is a potent predictor of mortality. Just referring back to the slides that we had on prognostication, and you remember that dyspnea was one of the symptoms that was targeted at being really of a bad prognostic index. And this for cancer patients as well as COPD or CHF. The more patient have dyspnea, the more difficult it is to manage, the closer to the end of the trajectory of the illness you are. In this multicolored slides, I try to illustrate what is involved, all the systems that are involved in dyspnea. And just to show you how complex this is, it is not just somebody is breathing fast, there are multiple systems that are involved in doing so. So we will have the respiratory system. We can have also the cardiovascular system. We can have or not have the hematology system, the musculoskeletal system that would be involved, the psychological one, the neurological one, and if you see that arrow that's going down, it represents the environment, because even though we have all those systems involved, the environment will play a great role, either increasing or decreasing the dyspnea. We'll come back to that. The etiology of dyspnea is very multi-causal. And it can be, let's talk about first of the cancer population, and then after that we'll talk about some others. Related to the cancer treatment, and other causes. And why we spend so much time today on the etiology, it is because it's very important. Contrary to some other symptoms, if it is not just suffice to say that we have a dyspnea and then we need to treat with medication. We need to find the cause, because if we find the cause, we can have a better treatment, a better management. Example, in the cancer, it is good to know if the dyspnea is secondary to primary or metastatic lung cancer, because then there will be something to do for that, maybe radiation therapy or something else. So it's important. Intrinsic or extrinsic airway obstruction by a tumor. This gentleman who came initially, who had a pneumonia, is that possible that he had a big tumor sitting there obstructing the bronchus and then cause post-obstruction pneumonia? If it is the case, there may be a treatment like stenting the patient. So we need to know. Is there pleural or pericardial effusion? Then again, there will be something we can do about that. Is it secondary to ascites, hepatomegaly, that just restrain the movement of the diaphragm? Phrenic nerve paralysis, superior vena cava syndrome? So for each of those, there will be a treatment of that entity, totally different than just the symptom control. Caused by the therapy of cancer, can be caused by surgery, can be caused by radiation, by chemo-induced pulmonary disease, chemo-induced cardiomyopathy. Again, it's good to know because for some of those, it may be harder to repair. Dyspnea caused by concurrent factors, and we have to be aware of all of that because all of those will play a role. Cachexia. When a patient loses a lot of weight, he becomes weak, he becomes more difficult for him to move his respiratory, his cage, his thoracic cage, just to breathe. So cachexia may have a role. Anemia may have a role. If your hemoglobin is too low, the carrier to the oxygen to the lung will be low too, and then patient can be dyspneic secondary to that. Pneumonia. Pneumonia is an infectious process, and then again can increase your respiratory rate. Pulmonary emboli, that's very interesting to know that patients may be or is at risk, as you know, with cancer patients are highly risk for emboli, and the story will be that it's come fast, it's something that is acute. Then again, the story will tell us a lot. Paraneoplastic syndrome and also pre-existing cardiopulmonary disease. When we have a patient with cancer, we oftentimes forget that they may have COPD, that they may have CHF, and then the treatment for those will be very different than just, adding some opioids or adding something. We may need to add Lasix or something to control the CHF of that patient. Pathophysiology of breathing. There's many things that have been involved. There's some research now trying to do brain scan, MRI, to see what connection there will be when patient in dyspnea. And we know for sure at this point in time, there's still a lot to discover, that's for sure, but we know that there's a big interaction between receptors, peripheral receptors, and also central receptors. So there is interaction between somatic, automatic nerves. There's also medullary response, respiratory center, central response here that's control the breathing, we know that. Central and peripheral receptors respond to humoral stimuli as well as vascular pressure. And finally, we have what we call mechanoreceptors that respond to changes in respiratory muscle tension. So it's a complex interaction between those four variables that more or less will be involved depending on the etiology of the dyspnea. So what we'll have when we have a dyspnea, there will be an increase in respiratory effort required to overcome the load, the increased load. Then there will be an increase in proportion of respiratory muscle required to maintain the workload. And then there will be an increase in ventilatory requirements. And all of that, that's the physiology of it, but all of that can be influenced or amplified by culture, environment, life experience, and psychological state. You can see that those come all the time, and you will probably discover why when we are going to talk about management. Assessment. Assessment is very important. I know that nowadays, being clinical, it does not, we don't put too much attention to being high clinician. We scan people, we do that, but it's not always possible to do that. And especially I'm talking about people who are dealing with patients at home. Before sending our patients to a CT scan, to a big investigation, to a big workup, we need to know what we are dealing with. And also to discover the etiology of the dyspnea, it's important to ask a few questions, because then we'll orient the patient this way or that way, and we will know what to start with. So self-report is the gold standard. Don't say patient doesn't look dyspneic to me. You cannot say that. You can not even write that. Patient is the gold standard. You can say patient is breathing fast, patient is using accessory muscle, patient seems to be hypoxic. You can say all of that, but you cannot say if the patient is really experiencing difficulty breathing. Assessment, we need, like pain, like any symptoms, the onset. As I was mentioning before, if the onset is very abrupt, we think about an emboli, and then maybe we'll need to do a test to suggest that it's emboli, will confirm that. The course, the severity, the exacerbating as well as the relieving factors, and the impact on symptom activities. And this is very important. We will see that there are scales that are measuring the impact on the activities, which is a way to see if patient is more or less dyspneic. So there have been multiple scales, and in the practice, in the daily practice, we don't want to have some complex scales that are not really helpful in a way. But there are two types of scales that can be useful, and one is the impact scales, effect on the behavior on the activities. And we ask that question all the time when we ask patients when we inquiry for patients' criteria for eligibility for hospice. We always ask the question, well, is he dyspneic at rest or an exertion? What is the impact? Can you walk? Can you go from one point to the other? And so we know. So this is kind of helpful to help us how the patient is able to master this dyspnea. There's also simple scales, like for pain, 0 to 10. 10 is you are very, very dyspneic, 0 you are not. Where are you? The importance of the scale is that you will start the treatment eventually. So when you come back after a day or so, or after the treatment, you want to know if you have some improvement. Since it is a subjective feeling, you cannot just say just by looking at the patient, that's better. So you will need to ask those scales and measurement. Assessment also include a past medical history. It's good to know if the patient was having asthma in the past or having some diseases that can predispose to have dyspnea. Physical examination. You can tell a lot by if you know how to do a good physical examination, especially if you are at home, by looking at, using your stethoscope or looking at the way the patient is breathing. Diagnostic studies, there's a lot that can be done. And this is why we need to know where we are going, because we cannot do all of them all the time. So we need to decide what and where we are going to start with. Social history, important, and psychological and environmental assessment is also great. So principles in the management. Once we know that, we have a pretty good clue where we are going. So now, how are we going to manage? There's a few principles that apply to whatever, if the dyspnea is really severe, moderate, or just light. And what we need to do is find the cause and treat the cause. That's the best thing, because throwing, bronchodilator, if you don't need those, this is useless. So we need to know what's causing the dyspnea. And also in sync with the goals of care. We are not going to do a CT scan of the chest when a patient has or come to you for dyspnea. It may be indicated at some time, maybe not at other times. So again, in sync with the goals of care. Let's go back to the case. Remember the 70-year-old man with long meds from a colon cancer. Now I'm learning from this man, which I did not know before, that he has a PPS score of 60%. He is walking, talking, eating, he's enjoying somewhat life too. And he would like to be treated if there is something to be done, because he thinks that his life expectancy is good enough for that. So therefore, a CT scan was done, and the CT scan showed two things: a pleural effusion and a lymphatic spread. So what shall we do now? We are going, two things, are probably contributing to this dyspnea. So we are going to see in the next few slides how we can manage, and we'll come back to that case in a little while. So management of a dyspnea management, the goal is really control the symptoms, maximize quality of life without prolonging or hastening that. So having a patient on a ventilator, that's good, but if we have some results going with that. Using opioids that may decrease the CNS, or benzos, the CNS will depress the CNS system. Wait, is that the time to use those, or shall I wait a little bit longer? And of course, accordance to the goals of care. This is something that in palliative care in a hospice you cannot avoid to do. Where am I and where am I going? So dyspnea management, two types of intervention, and the first type is the non-pharmacological. I start especially with that because I know that usually we always go to the pharmacy and then use this and this medication. Let's start with the non-pharmacological and then we'll go to pharmacy. So in the non-pharmacological, there are multiple interventions, and there will be medical, environmental, cognitive, complementary, and as well as other. Let's go through that, and as you can see, all that is put on one slide because I wanted you to have just an overview to see how many things there is to do. So to know if you should go with the medical intervention or with the complementary or with the environmental, we need to know what's the problem. And so this is why I keep saying and coming back to knowing what is the cause of the dyspnea will help you to choose amongst those 5 categories. Medical intervention, a lot can be done. Radiotherapy, chemotherapy, mainly radiotherapy though, can be done to reduce the size of mass or the bleeding, example, in the lung mass. So that can be very useful at times. Pleurodesis, thoracocentesis, cardiocentesis, the 3 of them, there's an indication for them, of course, and we most of the time we need the consultation with pulmonary to help us to choose which one would be the most appropriate, and depending of, again, how much fluid, and depending, of course, of the condition of the patient as well. Transfusion, shall we not transfer? A patient is short of breath. Hemoglobin is 5, but is not short of breath. So you can see that that will be very important. Patient has good relief from transfusion, previous transfusion, so shall we transfuse again? Oxygen therapy, we'll come back in a minute on that. Oxygen therapy is not a panacea for dyspnea. We have a sense that if patient is dyspneic, well, let's throw some bronchodilators and also let's throw some oxygen, and then that will do it. Not at all. If it may not help at all, let's put it this way, that oxygen will be helpful only if you have a patient with hypoxia. If you don't have, it will probably not be useful. Patients, maybe it's useful because it's in his nose, he receives a little bit of air, but that's not really the oxygen per se that is helping him. DC or decreased parenteral fluid. How oftentimes we are called in consultation to see a patient who's receiving 150 ml an hour, and this poor patient is having gargling, a lot of secretions, and as a pleural effusion. So of course it's third spacing, and then the treatment of that, you may want to put oxygen, but the best treatment will be probably to decrease the IV fluid. Environmental intervention. Positioning. Positioning is always there, is always important. And it is to the patient to determine which one is the best position. Pillows, sitting in side of the bed, sitting with the hands on the table. There's many ways, and they are the one who will decide which one is the better position for them. Schedule of activities. Avoid to have too much activities at the same time. Schedule that through the day. Room environment. You don't know how oftentimes I think that the room environment is the cause of increasing dyspnea in our patients. It's not unusual when you make rounds to have, example, heat in the room. It's so warm that you can even yourself hardly breathe. 10 persons in the room, loud, light, flowers, name food, you have the space sometimes is so confined that no wonder why you are short of breath. Durable medical equipment is also very important. We know that we need those recliner, we need those equipment that may help sometimes the patient. Cognitive therapy, multiple that are done. It's not always, the difficulty is not to always find somebody who are trained in doing those techniques. But if you have a patient who is open to that, relaxation techniques of any kind, as well as stress-reducing techniques, can be very helpful in reducing the difficulty of breathing. Complementary modalities as well, acupressure, acupuncture, yoga, have been described to be helpful. Again, there is not evidence-based. There have been multiple publications on that. Sometimes they will conclude, yes, it's good, sometimes not so much so. I think that if you have a patient who is open to that culturally, and I think that that will be a good, you lose nothing by trying, and it may help the patient. Now, let's go to the pharmacological interventions. And again, there's two types. You see how I keep adding in the treatment or in the management. First, you need to find the cause, treat with the cause. And then you go with the medication, and then there's two types. There's the one that will help the contributing cause, will have an effect on that, like the bronchodilators, like the diuretics, like the steroids. And there's the one that will simply help us for the symptom relief. Probably these are the ones that will be helpful all along the course, but probably more useful at the end of life. So let's talk about the opioids. The opioids, even though the data research is limited, it seems that there's some positive data in cancer-related dyspnea, overall decrease in dyspnea symptoms. So the mechanism of action is unclear. As you know, we do have some receptors in the lungs, but the action really, we are still looking for it to explain exactly what's happening. Keep in mind that, again, in everything that I'm going to say, opioids and some research show that it may be good for certain type of dyspnea, example, dyspnea related to cancer, but not so much so to other type of dyspnea. So as you know, because the cause may be different, the explanation may be different, therefore also the treatment may have different impact. So certainly for cancer, advanced cancer patient, opioids is quite good. Certainly most of you who are in the field have noticed that as well. The suggesting dosage is the following. If the patient is opioid naive, never been an opioid before, you start in a slow dose, like 2.5 to 5 milligram IV sub-Q morphine or 10 to 15 PO. Again, if you are elderly patient population, reduce that even further down. Try that in a slow mode, in a Q4 mode. Never start with a long-acting because you never know how the patient will respond to that. And knowing that the opioids decrease the CNS drive, you may end up with more sedation than you wanted to have. And for the opioid tolerant patient, we suggest strongly to increase by 25 to 50% of the already standing dose. Use of nebulizing of opioids, it was in fashion in the 90s. There was a lot of studies since then, and it's unconclusive. It is not damageable to the patient. There's not adverse effects that, you know, preclude to use that, but it's not so what we thought in a sense that we could use that over and over again. It is not had demonstrated that is really any significantly better than the IV or oral opioids. The benzodiazepine, again, controversial. We use them, but I think their maximum effect and their maximum benefit, shall I say, will be for patients who have a high component of anxiety that's increasing the dyspnea. Otherwise, they may simply depress the CNS, and then have a patient who is sleeping too much. And as you know, we don't want to cut too much the drive of breathing on patients who have dyspnea. The phenothiazine also is another class of medication that has been used with some beneficial effect. Personally, I have absolutely no experience with those two drugs, but it is recommended in the literature. Oxygen therapy, we already discussed about that. You know, the data, it's supporting data for that is not really, as I said, it's not a panacea. It's not everybody, patients with dyspnea who should be on oxygen, absolutely not. Just an anecdote, if you go in England and visit their hospice institution, there's no oxygen on the walls. It's just a little bit of a fuss that we are doing here. We feel better. We think that it's good to have something in the nose, especially it's probably the humidity that is coming with the oxygen. If you use oxygen, use humidified oxygen and nasal cannula, and please do not give more than 4 to 5 liters through a nasal cannula because it's just a waste and it won't just give you more results. Steroids can be miracle. It can be miracle in some circumstances. 3 of them I can mention here. Is extremely useful in carcinomatous lymphangitis, supravena cava syndrome, and bronchospasm caused by COPD or asthma. Usually, we suggest the patients with COPD, usually pulmonary, tend to use, we suggest prednisone. For cancer patients with either vena cava syndrome or carcinomatosis, we try to use dexamethasone, which is a longer acting and give you a better benefit. And the dose is really not a high dose, it's usually 4 to 8 milligrams a day. Bronchodilators, of course, useful most of the time because it's part of the dyspnea process that you will have some bronchospasm there. And so nebulized or oral bronchodilators can be very useful. Be careful though in the combination that you are using because some are dry agent and some are mucolytic or increasing secretion agent. So the drying agent is albuterol and ipratropium, and those two will dry the secretion, will dilate the bronchus and help us to alleviate the airflow obstruction. The mucolytic, which is mucomist, better known on that, can help producing secretions. And then again, it depends what you want to do. Don't use both at the same time because they will be counterproductive. So make sure that when using some bronchodilators, what is they are going to do. And they can be combined with steroids as well. As you know, there's multiple combinations on the market. Aminophylline, theophylline, very old drugs. They can help as well. They have a little bit more side effects, but they can be helpful too. Diuretics, diuretics can be useful, of course, if you have CHF exacerbation, if you are pulmonary edema, things like that. That would be extremely good. There has been a tendency recently to use nebulized furosemide. That has been studied in the last 5, 6, 7 years, something like that. And some of us tend to propose that when everything fails and as anecdotal, because I don't think that if you look at all, and I did a review of literature on that, that it is strong enough to say that we should use that automatically or very often. There's a maybe potential benefit, and that's something that we use that in a few of our patients with some effects, but then again the literature is not strong enough to recommend that for all the patients. I'm going back to my gentleman. Remember, we left him. He has pleural effusion. He has also lymphadentic spread. So he had a thoracocentesis. That was helpful. Why not a pleural disease? Why not putting a pleurex? Then again, I think that this needs to be addressed and discussed with the pulmonary consultant. For sure, we see more and more of all those tubes, either for ascites, either for a pleural fluid. We have to have a certain amount of time to live, a certain prognostic. We don't use those devices if we have a few weeks, a month to go. Probably nobody will do that. So again, as you know, it goes back to the famous question of where are we in the course of disease and what are the goals, what I'm doing here. So shall we start steroids on this gentleman? Remember we said that not only was having a pleural effusion, but he was having also lymphatic spread. And for the one of you who had those patients in the past and used Decadron, it can be marvelous. And if you have that, it's worth a trial. Again, it's anecdotal, but it's certainly part of the palliative care literature. A low dose of steroids like 4 mg BID can be very useful to decrease that, to help from this etiology. Other modalities, it depends. We saw many, as you saw in our chart. Of course, there's always other modalities. Just before we are about to conclude in a few minutes, let me just and refer you to the American Thoracic Society guidelines that for mild, moderate, and severe dyspnea. And again and again and again, they insist, treat the underlying disease. You need to know what you are dealing with. You need to know what's the cause of your dyspnea before starting any medication and so on. So I think that I refer that to you. You'll see also, I will mention that article into the bibliography. The American Thoracic Society did an extensive review just on dyspnea, mechanism of action, the treatment, the etiology, the assessment, and so on and so forth in 2012. I'll give you the reference in a minute, and you'll see how it can be useful if you plan to further explore this symptom. Let's see a total finishing of this case to raise some other issues. And as you can see, and that was why I put this case alongside and not just in one time, because as you know, dyspnea is evolving, especially when it is due to the chronic causes, and it's mild, then it becomes moderate, and then it becomes it's very more severe, and the treatment will change also along the course, and this is what I wanted to exemplify with this course. So 4 months later, patient had Thoraco, he had Decadron, and it's still, it had improved somewhat, but it recurred and it's worsening now. And now its PPS is less than 40%, and what shall we do? Are we going to repeat the CT scan, think about the thoracocentesis? We may not. It depends. We will probably do chest X-ray and see if there's something that can be alleviated simply. We may not. It depends what kind of condition the patient is. We will certainly use bronchodilators, and we certainly will use morphine. And if he's hypoxic, we don't know. It's not saying that. Maybe oxygen. We do environmental, of course, issue, maybe acupuncture. So there will be a lot of things to consider. I put here the code, and I should have put that probably earlier. The minute you know that we have a patients with those chronic illness, COPD, CHF, and involvement with cancer, you know that it will progress, and you know that you will have an ending at one time, and there will be not much that will be able to be done. It is very good to discuss early on with the patient, if he's open to that, what if you cannot breathe anymore? Intubation, not intubation, BiPAP, no BiPAP. And also code, no code. It's not when the patient, and we've seen that so many times, patient is barely able to breathe, and then, oh, do you want to intubate? Of course, who's going to say no? Nobody's going to say no. Help me, do something, anything to make me breathe. So I think that that's important that we address that early on. Conclusion here, approach dyspnea in advanced disease. Dyspnea is distressing, very distressing. If we think that pain is distressing, dyspnea is every single breath that really is distressing. It's subjective, so don't say it doesn't seem to be dyspneic. You cannot say that. It's constant most of the time. Dyspnea has multiple dimensions. Look for it. Look for the cause. Be sensitive also to the multiple management approach. Dyspnea does not equal bronchodilators, does not equal oxygen therapy. Opioids should be considered first-line therapy for dyspnea in advanced disease. You probably will need that. The second-line agent can be chlorpromazine, metoclopramazine, and anxiolytic also will be useful. Although we don't have convincing level 3 evidence, there is enough there in the literature to say that it's helpful. Let me finish up by a case that is a very, very different case, and that's a case of a gentleman with COPD this time. And this is a typical history. They have COPD, they are admitted for pneumonia, 1 pneumonia, 2 pneumonia, 3 pneumonia, and finally they have a complicated pneumonia that is complicated by respiratory distress and need intubation. So this patient was intubated, extubated, now is on BiPAP. And I don't know if you had many patients on BiPAP, but this is that's a technique that can be very intolerable for the patients, and some do not want that. So this patient is asking, please take me off that and I want to go home. Remark that we can go home with BiPAP, but this one, it's the BiPAP, it's not necessarily the going home, that's the issue. What shall we do? Are we going to respond to that demand? We had such a demand a few years ago for a patient coming with the step-down unit and barely able to breathe on a BiPAP 24 hours a day. What did we do? We tried to say, well, listen, you want to get rid of this BiPAP? Let's try. We may be able and we may not be able. Okay, with the help of respiratory. What we did is that we were taking off the BiPAP for some small period of time, putting just nasal cannula and see how the patient was doing. And we repeat that for many days, up to the point that the patient was able to breathe without the BiPAP. But meanwhile, we were using also a low dose of opioids, as I mentioned in the course earlier, a low dose of, and we build up our opioid up to the point that he was able to tolerate very low dose. I'm telling you, for COPD, they don't need big dose, 15 milligram MS content BID, and was enough. We were able to control the dyspnea with those two techniques, and the patient was able to go home. So it's not working at all time. It depends if they are, but just to present to you another way to manage patients with a different type of disease. Now it's time for a question. So even I took a little bit longer time, so maybe the question period and the answer will be a little bit shorter. Meanwhile, while I'm looking, just look at the bibliography, and I would like you to look into the recommendation that I was doing for the major articles, I think, for dyspnea, that will give you a great review on the symptom. It's an official American Thoracic Society statement, and that was published. So this is the last on the slides on the bibliography. This will be the last recommendation, and that was published in 2012. So somebody was asking to distinguish dyspnea from tachypnea, and I hope that you notice that the dyspnea is not always accompanied by tachypnea. But as you can see in the pathophysiology, if the demand becomes too high, then the patient, in order to compensate, will increase his respiratory rate. So it comes a point that it goes so fast that he cannot, patients cannot have enough oxygen. Finally, is just like using his accessory muscle, and they become, what happens is that the patient becomes very tired. So then at this point in time, and even probably much before, we need to settle down and try to find the cause that is doing that, rapidly set the patient down, because it will become exhausted, and finally that will be terribly distressing to him and as well as the family. So tachypnea is just an increased rhythm of the breathing. It's not always that with dyspnea. Patient can be dyspneic and say, I have difficulty breathing, but not breathing necessarily fast. What if patient, so we said that that dyspnea, the gold standard is really the patient. What if patient denies dyspnea but manifested all the symptoms of dyspnea? Well, you know, we have the same phenomenon with pain. Some patients, we know they are in pain, they have to be in pain, and they just say no, they don't want to be treated. Sometimes just afraid to be treated. Don't forget also it's afraid to say, well, if I show that I'm saying that I'm more dyspneic, it's because I'm sicker. And so there's a lot of psyche that plays with that as well. We cannot treat a patient for dyspnea if he says he's not dyspneic. We may notice his respiratory rate is faster, so we may want to suggest something to calm down the respiratory rate, but we cannot say that we cannot force him to be treated for dyspnea. We can perhaps treat what we do see. With PPS of 40%, would this be considered for hospice? Yes, as you know, and just refer back to the slides that we were having on the prognostication. And usually patients with lower prognostic score than 50% are eligible for hospice. They have, because by that time they have multiple things that really are not go. And 50%, remember, was starting to be significant for prognostic in months and not years. So then, yes, PPS of 40% is certainly will be considered for hospice. Yeah, so if a patient is not verbal, how are we going to see if it is tachypnea or it is dyspnea? We can certainly assess that it is tachypnea because we'll see patients breathing faster. We cannot say, though, how distressed he is by that. So we will use common sense and clinical sense to do with combination perhaps of some chest x-ray, something like that, to see what's going on with the patient. Couple that with the blood pressure, couple that with the assessment that we do have, in a sense the patient is known to have COPD, is known to have CHF, and then we'll try to correct that, but we will not be able to say how distressful it is. Probably for the patient, we will not be able to evaluate that. So we'll be able to evaluate if we decrease the respiratory rate from, I don't know, a 40 to a 20, we'll see that, and we may presume that the patient is breathing better, but we won't be able to probably say the difference. If compression of spinal nerves due to meds, the patient has dyspnea, could be different from the. I think that if you have patients who will compress nerve root, that won't give you much. It could give you some paralysis a little bit. You may have more difficulty breathing. You may not move as much the thoracic cage. And then if the compression is high enough, he may need to be on a ventilator to move because he won't be able to move. So it depends where is your section of the spine, at what level that is. Just the root won't be enough to do that. But keep in mind that if you have roots that are involved and that will give you pain enough for the patients to restrain his breathing because he has too much pain, then you may want to consider a block, a nerve block that may help to decrease the pain and then help worsen breathing. Don't forget that dyspnea is not a symptom that's totally isolated from the other. There's a lot of connection between dyspnea or tachypnea or anything related to the breathing and pain. Example, there's a big involvement. You know that if you have pleural metastasis, you will have pain every time that you are breathing. Therefore, the treatment of that was to deal with those meds that are there, either by chemo, by RT, or any modalities that can be, or nerve block if you can. So again, conclusion, please keep in mind, find the cause and know how to deal with that. But that's not enough, is the case that we have under our hands, is the patient that we are treating is is he a candidate for such and such therapy? So goals and the cause are the main two things that we should think about in dealing with dyspnea. Now let me conclude here by reminding you, please do your evaluations. It helps us to see if we should improve or not improve. Also, if you have suggestions, that's very good. And do not forget to maybe tune in 2 weeks for an interesting talk about recognition and management of the imminently dying by Dr. Russell Portnoy on April the 9th. Thank you.